that uncommon.
He's 17 years old.
Yeah.
He wouldn't want me to say this, but he's the thin. I mean, he's muscular, you know.
Yeah.
But you know, he's not has any extra weight. I mean, he's trying to gain weight right now, but it really started to bother me. I think it's a problem, and if you talk to the physician that I've talked to, which I dearly love, in this case, you know, they ask, well, do you get in trouble at school? No. Do you get good grades? Well, no. Yes. I mean, he makes straight A's. All those questions, I said, well, then don't worry about it, you know, and I think it is.
Yeah, and again, it's at least.
I'd say he takes 2 or 3 hours to go to sleep.
Wow. Okay. Yeah.
He really can't go to sleep, and he's not watching TV or anything. And I've told him to pick up a book and read, and you know, I really see him trying to do different things.
Doing the right things. You know that, and again, it wouldn't be inappropriate, I don't think, to maybe think about seeing a sleep specialist about that. You can take heart in the fact that, again, it looks like it's not impairing his level of function to the point where he's not doing well in school or not succeeding athletically or doing those kind of things. So that's reassuring to us. But yeah, I can understand that concern, and I would be concerned too if my kid was struggling 2 or 3 hours a night to fall asleep, even if they were functioning. Because again, right now, when they're young and otherwise healthy and have great energy, maybe they can compensate and maybe they can get by. But what happens if this isn't addressed and if this continues when he's in his mid-20s or mid-30s or mid-40s, when he doesn't have that reservoir of adolescent energy to help carry him through? And is that going to, you know, if he was having that kind of sleep disruption at our age, that would probably take much more of a functional toll on him. So I don't think it's anything to be overly concerned about, but I think it's not an inappropriate thing to maybe talk to a sleep specialist about and say, hey, is this would it be worth thinking about doing a sleep study and seeing what's going on here? You know, it depends. We're a little reluctant typically to use prescription sleep medicines in younger people. There's no prescription sleep medicine that's approved for people under the age of 18. Now, obviously, he's sort of cusping on that age, so by the time he would get in and get evaluated, he might be 18. So some people might think that he might be a candidate for a medicine at that point. But sometimes it can be, again, just taking a more careful sleep history and finding out, well, he's doing this or that. There's also one thing I failed to mention is the impact of cognitive behavioral therapy on sleep. There are specific forms of therapy, of what we call cognitive behavioral therapy, which is a really great, very practical, pragmatic, nuts and bolts type of form of therapy to help people with sleep, because we get twisted when we can't sleep. We get just twisted up with anxiety and concern. Oh my gosh, I can't fall asleep. I'm going to be a wreck tomorrow. I'm not going to be able to perform. I've got this interview tomorrow. I'm not going to be on my game. And to be honest with you, one bad night's sleep, almost anybody can sustain. Even not sleeping at all, most people get through the next day okay. What is a bigger impairment to them probably is the anxiety about not having slept and the worry, rather than the actual impact of one bad night's sleep. So cognitive behavioral therapy can be a really effective way to help people diffuse some of that anticipatory anxiety, some of that anxiety where you're thinking, oh my gosh, I didn't sleep well the last 2 nights, I'm not going to be able to sleep well now, I just know I'm not going to be able to fall asleep, and that anxiety then becomes another trigger for the insomnia. So cognitive behavioral therapy can really help with relaxation, with uncoupling some of those automatic assumptions or thoughts you have about, oh gosh, I'm not going to be able to fall asleep, and just sort of helping people understand that, hey, even if I have a bad night's sleep here and there, that's not going to just wreck my level of functioning the next day. The difficulty sometimes is finding people that are knowledgeable or skilled in doing cognitive behavioral therapy specifically for sleep. But there are other forms of therapy. There's other forms of cognitive therapies for sleep. There's relaxation training. People sometimes do things like, visual imagery, biofeedback, relaxation therapy. Muscle relaxation probably doesn't work as well, at least according to the studies, as cognitive behavioral therapy or as medicines do. But there's a lot of different tools out there that people can avail themselves of. And especially with younger people, we're more likely to explore those to a greater extent, since we're, in general, less likely to use medicines than people under the age of 18.
Chris, I might just to go a little bit further on that cognitive behavioral therapy piece and what that really is. the cognition is the thought.
Right.
So like you mentioned, we have these automatic thoughts that, oh man, I'm not going to be able to function. If I miss this night's sleep, I'm not going to be able to function. And the other thing is a common thing that we do, and I always do, is I wake up, look at the clock, and then I'd say, oh, it's been 15 minutes, I haven't gotten to sleep. Well, it's been a half an hour. Geez, now it's been an hour. I'm never going to get to sleep. So you cause this huge adrenaline release. It's an anxiety response, and you're not going to sleep when that happens. So, so the behavioral part of that then is of the therapy that they do is that the therapist will help the patient there, help the person come up with things to do. Like, what would you do? Well, first thing is kind of obvious: turn the clock. So you don't know how long it's been, so you don't sit there and panic about that part of it. The next thing is, if it feels like it's been 10 or 15 minutes and you haven't gotten back to sleep, get out of bed,
right,
so that you don't start associating your bed with anxiety. Get out of bed, go into the living room, and read a boring psych textbook. Is what I always tell my patients. I'll loan you a psych textbook. That's nice and boring, something will put you right to sleep. But anyway, something boring. Don't go in and watch Terminator 2 or watch some big action flick or play video games and blow up a bunch of aliens. Nothing that stimulates you. You want to go in and do something comforting and relaxing. When you start to get sleepy, you go back and you lay in bed until you fall asleep. Again, you do the same thing again. If it gets to be 15 minutes or so, then you get back up. But you stay on your sleep cycle.
Yeah.
Like you mentioned earlier, you stay on your sleep cycle and you get up still. Even if you only got 3 hours of sleep that night, you get up at 6 a.m. or whatever time you've chosen. You don't nap the next day, and by the time 10 o'clock or whatever time you've chosen hits the next night, you're going to be exhausted. We call that sleep pressure. So that's the cognitive, the thought piece and the behavior piece. You change those things to try to help you get to sleep, and it's extremely effective.
Exactly, and it's something that we don't think about enough because it sounds like, well, it's so common sense. How could that possibly be helpful?
Yeah.
But it really is. And again, the other thing that's important to point out is that you can't pay back a sleep debt. You can't catch up on missed sleep. So it doesn't make sense, and you're actually probably hurting yourself if you get into that pattern of, I didn't sleep last night well, so I'm going to take a nap today. No, just struggle on through that and stick to your normal sleep-wake cycle. That's the most reliable way to wind up back in a good sleep-wake cycle. In fact, there's even places that are doing sort of taking that sleep pressure thing one step further, and they're doing sleep deprivation as a way of treating insomnia, where they'll bring people in and keep them awake for 36 hours or 48 hours. And sometimes it really can have a nice effect on helping to sort of reset that circadian rhythm. You almost always have to take somebody someplace to do that, because just telling people to do it themselves at home almost never works. But
in the older adult population, that's classic, because they don't have to get up and go to work.
Right.
And I don't sleep at all during the day, but the family says, I go in and Grandma's sitting in the chair with her eyes closed. Maybe she's not sleeping, but she's resting her eyes. Well, what do you call it?
Right.
Probably
Resting my
there.
eyes.
And then her body gets to sleep out during the day, and then it comes nighttime when she wants to go to sleep, she can't get to sleep. So
Exactly.
that's a extremely common thing. The behavioral piece, I think, we underestimate a lot.
Yeah, and we get so much anxiety and worry about, oh my gosh, I'm not going to be able to fall asleep. It's a double-edged sword. Then it just comes around and sort of bites you the next night.
Right.
Other questions that folks have, or comments, or?
Do you know why in menopause women seem to have insomnia?
Great. The question was, why is it in menopause the women seem to have more trouble with sleep? A variety of reasons. Number one, just some of what we call the vasomotor changes, the hot flashes, the night sweats, pretty disruptive to sleep. Also, estrogen and progesterone have effects on sleep architecture and have effects on sleep. So as you approach menopause and as your ovaries decrease the amount of estrogen that they're producing, as you see falling hormonal levels, that can cause problems with sleep. Even if you look at a woman across her menstrual cycle, you'll generally see higher levels of estrogen, which is sort of the first half of your menstrual cycle, being associated with better night's sleep, and then higher levels of progesterone and lower levels of estrogen being associated with less good sleep, less restful, less restorative sleep. Actually, these hormones also impact your risk for sleep apnea. Women are somewhat protected from sleep apnea compared to men during their reproductive years, partly because there's some evidence that these hormones are almost like respiratory stimulants in a way. It almost can stimulate your drive to breathe. Also, estrogen in particular, and maybe some of the other reproductive hormones, seem to have an effect on strengthening the muscles in the back of your throat to help keep it open. So you're less likely to have your throat closed in the middle of the night and have sleep apnea and obstruct your airway if you have good levels of estrogen. Interestingly, after menopause, women's levels of sleep apnea really go up pretty dramatically, and they're just as much risk as men are after that. So there are a number of things going on around menopause that can contribute to our vulnerability to sleep-related or to breathing-related sleep disorders, and also just may play a role in insomnia. I had a patient in my office that I had seen again last week, and she was convinced that this antibiotic medicine that she had been prescribed had wrecked her sleep. And what we really noticed was that as we had her chart her sleep out, this was really having an association with her menstrual cycle. She was taking this antibiotic once a month, and it sort of happened to be around the time that she was ovulating. So we noticed this tie-in between the times of her period when she probably had more estrogen in her system, she was sleeping better, and then later in her cycle, her sleep just fell apart. So there's a lot of reasons, and we're just sort of beginning to understand this, but there are some hormonal effects on our ability to sleep and our ability to sleep well.
And, you see a lot of commercials for sleep, okay? And one of them that we see a lot of, and I'm sure everybody here sees a lot of, is restless leg syndrome.
Yeah.
Can you mention that for a minute and explain what that is?
Yeah, restless leg syndrome is what's called a movement disorder. Restless leg syndrome is the sensation of, people talk about it in different ways. I had one patient describe it as, my legs were having panic attacks. Other people talk about creepy crawlies. And it's not pain, and it's not your legs jerking. You know how sometimes your legs jerk right as you're on the cusp of falling asleep? That's something different. Restless leg, your legs may not move at all on their own, but you have this sensation where it's just intensely uncomfortable. It's typically not painful, but it's just this feeling. It's like, gosh, I almost got ants crawling on them or something, or they're just I got to move them. And the only way I get relief is by moving them or getting up and getting around. People are vulnerable to this in different stages of their life. You can see it in childhood sometimes, actually significantly associated with what we call growing pains. A lot of kids, when they're going through growth spurts, will have this happen. Women are more vulnerable to this than men are, partly because one of the things that puts you at risk for restless leg syndrome has to do with your overall iron stores in your body. And so since women are losing blood monthly with their menstrual cycle, they have some relative anemia in general compared to men, and they may be at greater risk for having restless legs. There are a number of medicines that can increase your risk for restless leg syndrome. Actually, antihistamines like Benadryl can make it worse. Antidepressants that work on serotonin can make it worse. And this, it affects people to varying degrees. I've seen some people that have it so bad that, it's just terribly debilitating. These people cannot sleep throughout the night. Their sleep is just horrible because they're up all the time, walking around, rubbing their legs, taking hot baths or hot showers to try to get comfortable. And it can actually progress to the point where it doesn't affect just legs. It can affect their arms, their trunk, and they can have it outside of the time of sleep. It's not necessarily just when people are asleep. You see it when people are just sedentary for a long time. So actually, I've got patients that can't fly. They can't be on a flight that lasts more than 3 hours because of their restless leg syndrome. And it was pretty poorly understood. We didn't understand what was going on with this. I actually had this when I was a kid, and I outgrew it, which is sort of unusual. But nobody knew what it was back then. I remember telling my parents about this. Oh, we got to call the car over. I just got to move. And parents looked at me like I was crazy. And my grandpa, one day, I was riding around with him, and I got to the point where I was almost crying about this. And I was telling him, and he said, Chris, he goes, I have the exact same thing. And I've asked other family members, and it was terrible in my family. My grandfather had it, my mom has it, my aunt has it, and I thankfully dodged it. I got out of it after childhood, but it really can be a horrible affliction for some people. There are some newer treatments that we have on it. Actually, some of the same medicines that we use to treat Parkinson's disease can be useful in treating restless leg syndrome, although restless leg syndrome is not a preview of Parkinson's. If you have restless leg syndrome, it doesn't mean that you're on your way to developing Parkinson's disease. But some of the medicines that have been useful in treating restless legs are some of the medicines that we use to treat Parkinson's disease, which is another movement disorder. And the commonality there is these are medicines that work on a brain chemical called dopamine. But a pretty under-recognized thing. It's one of these things, if you start asking friends and family, or if you ask your patients about it, and they're like, oh yeah, I see that. Or people see these ads on TV, and it's like, oh my gosh, I thought that was just me. I thought I was just crazy. I didn't know that was actually a real condition. So restless legs, and then something that else people can see, which is periodic limb movement disorder, where it's not like that creepy crawling feeling so much. It's more like every once in a while your legs will sort of jerk or move on you, which can also be disruptive to sleep.
And then there's also nocturnal. Oh, I'm sorry. Go ahead.
I was just going to ask about waking up in the middle of the night and then not being able to go back to sleep for several hours. Is there
just some of the sleep hygiene strategies that we've talked about in terms of not staying there in bed, getting out of bed, getting up and doing something, reading, listening to some music, and then wait until you're sleepy and trying to go back to sleep. If you've tried that and that's not helped, sometimes we will use sleep medicines. Now, again, even though you may not have trouble falling asleep, if the problem is, hey doc, I fall asleep fine, but gosh, every night my sleep's broken, I wake up in the middle of the night, sometimes that can still be effectively treated by a medicine that you take each night at bedtime, provided it lasts long enough in your system to carry you through the night. Some of the shorter-acting sleep medicines, if you're having just a problem staying asleep, some of the shorter-acting sleep medicines may wash out of your system enough that you're still going to wake up in the middle of the night. There is one sleep medicine on the market that is very, very short-acting, and occasionally I've even used this for people that wake up in the middle of the night, and I'll say, okay, if you wake up in the middle of the night, and if you've got this pattern where when you're up for hours, go ahead and take this pill, because it can kick in very quickly and wash out of your body within about 3 or 4 hours. So I usually tell them, as long as you've got 4 more hours you can be in bed, you could take this pill in the middle of the night. That's probably not as good of a strategy as trying to treat it up front and catching the horse before it gets out of the barn. So even if you're not having trouble falling asleep, if you're having a consistent problem staying asleep, medicines could still be a reasonable treatment for that, but it might be important to focus on one of the medicines that's more likely to last longer, as opposed to one of the shorter acting sleep medicines, which is more appropriate if your problem is just falling asleep.
Yeah, I think one of the keys too, Chris, is that just figuring out what is the cause of, if you can do that, figure out what the cause of the sleep is. If you have sleep apnea, for instance, you don't really want to use sleeping pills for that, because that's a person who's, they're not getting air, they're not getting oxygen. That's what's they're waking them up. Is the brain saying, hey, there's not enough oxygen in the blood. You got to wake up or you're going to die, right? Well, then all of a sudden I use a sleeping medicine and I put them to sleep so their brain doesn't do that anymore. Well, what can happen? Well, it's not a good situation. So usually you want to try to avoid medicines in that situation. So, it's not so easy as there's one answer that fits everything. You really need to know what it is and try to figure that out. I think it strikes me, though, that the behavioral piece is super common. I think we just don't use it. Yeah, we don't. Maybe it's because it's harder. It's harder.
It's usually just thinking about things, thinking about stuff.
Yeah.
And I can't go back to sleep.
Right.
I can't shut this thing off like this.
Yep.
Yeah, and again, sometimes there are other things going on. Sometimes people have sleep disorders that are associated with or secondary to depression or anxiety or attention deficit disorder. Last month's topic for this series. Attention deficit disorder, a lot of the medicines that we use to treat attention deficit disorder, the stimulant medicines, can cause insomnia. But one of the things people don't think about very much is that people with attention deficit disorder have trouble sleeping even before they go on meds. Because sleep is an active process, and sleep requires your brain to function a certain way. And so if you have ADD, sometimes people have a hard enough time shutting down their mind enough to be able to engage in the active process of sleep. So you also want to make sure that if there's something else going on, that we're paying attention to that. So if somebody's not sleeping because they're depressed, we want to treat their depression. If somebody's not sleeping because they're anxious, we want to treat their anxiety. If somebody's not sleeping because they have ADD, we want to treat their ADD, and there's a good chance that their sleep will improve then.
You had mentioned earlier about allergies. Can cause sleep apnea?
Well, to the extent that the allergies can worsen your airway, can obstruct your airway more. So, for example, if because of allergies you're having a lot of mucus, or the back of your throat is sort of swollen, or your tongue is sort of swollen because of environmental allergies, that can contribute to like a breathing-related sleep disorder like sleep apnea.
So, what I have a problem with, and I've always thought that it was my allergies because I arrested for him, but my snoring is so embarrassing. But I never had in my life until I was allergic for the first time. There was a dog in the house, and then I had very severe anaphylactic shock and all that. Took the shots, and they really were frightening to me because I really would react terribly to them. So I got better, but the snoring never went away. They were definitely came at the same time. But what's really funny, because I think this is so strange, but it worries me too, because when I could go to sleep in 3 seconds.
Mm-hmm.
But what is really funny is I can hear myself snoring immediately. I can hear myself.
Yeah.
It's not possible. I hear myself, and I know I've only been asleep about 3 seconds.
Yeah, and that's not uncommon. You can't, because people will snore sometimes even before they're asleep. You get to that what we call stage 1 sleep, which is really sort of a transition stage between waking and sleep, where you sit there and like, what do I do?
Wake yourself up.
Yeah.
But I couldn't possibly be getting. I think I'm sleeping good at night, but I'm told that I'm not. That I toss and I turn and I say things. Can that be dangerous to do that? To keep doing that, because I don't feel rested?
Well, if you're obstructing and if you're getting to the point where you're decreasing the amount of oxygen that's getting into your blood, or you're obstructing your airway enough that you're, waking up like that. Yeah, even if you're otherwise feeling like your energy is okay during the day, that can still be enough to put an additional burden on your heart and lungs.
So the only way to know that is from the sleep study, because I hear myself, and then you kind of just tell yourself, okay, stop that.
Yeah, although there are some other alternatives that are becoming available. There are some other alternatives to formal sleep studies now. For example, there are devices that some primary care offices are starting to keep on hand, where you can actually you can give these things to patients. You can take them home overnight. You put these things on, and basically it measures the amount of movement each night, and it measures your breathing. And it's probably not as good as a sleep study, but the correlation between that and a full-blown formal sleep study is pretty good. So it may be a more effective screening tool for a case like this, where you're saying, gosh, I'm not having all this horrible daytime sedation and the other things I might normally associate with sleep apnea, and I'm not sure if I want to spend the money or if I can convince the insurance to cover a full sleep study. This is certainly better than not doing anything. It doesn't give you as much data as a full sleep study does, but it's not a bad screening tool.
But it's allergies. What can you do?
Well, just other than treating the allergies, yeah. But if you've done your best to treat the allergies, then still, I guess if the obstruction was bad enough, you might still wind up on CPAP or BiPAP. If you were otherwise unable to treat the allergies to the extent that you could clear up that obstructive problem at night.
What role, if any, does light therapy have?
Good question. The role of light therapy. Light therapy is tied in with the whole melatonin cycle. The presence of light essentially deactivates melatonin. So light entrainment, it can be an effective way for some people to help regulate their sleep-wake cycle. You want to talk to people that have bad sleep, talk to people that are at the poles. People up in the North Pole or people down in Antarctica. Wow, great way to mess up your sleep cycle. Astronauts. NASA is very interested in medicines that help with wakefulness and help with sleep, because nothing messes up your circadian rhythms like having a sunrise every 97 minutes as you're flying around the Earth at almost 100,000 miles an hour. So that really messes up. I was doing some lectures down in Houston and got a chance to speak with the flight surgeon for the shuttle missions, and they were talking about this as being a big interest, because it really can take a toll on people. It's just like they have no idea, they lose sense of time, and they don't know how long they've been up there. So light therapy can be effective for that. Light therapy is also sometimes effective for depressive disorders, for mood disorders. It's like everything else in the world. It's not magic. People fall out on a bell curve. So for some people it works amazing. For some people it doesn't do a thing. Most people fall somewhere in the middle. And generally what you want to do is you want to have light that approximates sunlight on a bright day, not lights like this. You need about 10,000 lux or 10,000 lumens, ideally given in the morning, ideally for anywhere from 30 minutes to an hour during the day. You don't have to stare at the light, but it does have to be hitting your face.
There's debate on blue spectrum versus...
Yes, some recent data saying that the blue spectrum light may be more effective. There's just one study so far that I'm aware of that's shown that. So I think we're going to need more data, but certainly doesn't seem to be any worse. At least it may be superior. But yeah, I do use that with patients sometimes.
You want to see the results of that. I mean, just here in the Midwest, think
Yeah.
about how hard is it to get up in the winter, it's dark, versus how hard is it to get up in the summer when it used to be anyway, before the time change. It used to be light. I mean, you'd wake up pretty quick when it was light, now, and actually, I started getting into that a little bit, and it's so hard to get up when it was dark. I bought this little mechanism that I hook up to my light that you set a little timer. About a half an hour before you're supposed to, if you want to get up at 6, about 5:30, this thing starts to come on and gradually lifts your light up. And so then, it's like somebody flicking the light on, but it's not sudden. It's like the sunrise, kind of, but I don't use any special spectrum or anything like that, just the regular thing. And I wake up much more ready to go than I would have before.
Yeah, and sometimes if you move to southern latitudes, it's funny because sometimes if I'm doing lectures in South Florida, in Southern California, in Hawaii, I'll get that question sometimes. It's like, is that seasonal affective disorder stuff really true? Does that really happen? Do people really get more depressed during the winter? It's like, move here for a winter.
Yeah,
and see what staring at gray skies does for you for a year.
Yeah, there's something to all that, I think.
Yeah.
I wonder how much effect it has on adolescents too, particularly now with the daylight savings time, because we're taking adolescents whose normal circadian rhythm isn't to go to sleep until 12 or 1 or 2, and now we're making them get up an hour earlier.
There are actually some school systems across the country who, in response to this data, have adjusted the school day, and where they say, okay, instead of having school start at 9 o'clock and go till 3, we have school from 10 to 4 now. And actually, some of the school studies have shown improvements on graduation rates, standardized to ISTEP equivalent kind of testing, and so forth. So.
It's amazing if you know the science behind how our bodies work and our brains work. It's amazing. If you could actually change society in a way that would match that, it would be so much better. The other example of that is having a nap at 2 o'clock in the afternoon for most people.
Yeah.
A little 15-minute nap. Where you're in the middle of your work day. What happens? I'm sitting at my desk today reviewing this document. It's kind of boring, but still 2 o'clock and I'm ready to fall asleep. You can't do that when you're at work, but it'd be nice if you could. And you've seen it on TV. There are companies that are now allowing. They have those little sleep, what do they call them, sleep centers or something in the office somewhere. So,
and a good chunk of the world does that. A good chunk of the world does take breaks in the afternoon and extended lunch hours and so forth. So, getting us to change our habits to match our biology sometimes is tough.
Right. And I think obviously the nap shouldn't be an hour or 2 hours, but 15 minutes, 20 minutes is just amazing. I don't know, you guys have probably done this before, but you drift off for 15 minutes or so, you wake up and it's like, wow, I feel so much better. And it was just 15 minutes, 20 minutes. Are there any other questions? I don't want to rush anybody, but I also don't want to have to keep everybody all night either.
Because you got sleeping to do tonight.
That's right. You got to get back to bed. That's right.
I think I got a question. I got a curiosity.
Uh-huh.
Went through the sleep test about 3 weeks ago.
Uh-huh.
Been on CPAP for about a week now. And I got kind of interested in this oxygen level type thing. I guess normal is somewhere close to 100. And I run about low 90s on normal. And in the test, I went down to low 80s. And I was wondering how much effect that has on your...
It's a good question. You're right. Most people that are in generally good health, if you put one of those fingertip things on them and you measure how much oxygen there is in their blood, we typically like to see that 96, 97, 98%. Getting down to the mid-90s, not too bad. Getting down to the low 90s may not be horrible. When you start dropping below that, or if you're dipping into the 80s, that is much lower oxygen than we're normally supposed to have. And remember, oxygen is basically one of the primary sources of energy for all the cells in our body, especially our brain cells. Our brain cells are different than the other cells in our body because they don't store energy. They don't store energy in other ways that their other parts of our body do, and that's why our brain is so sensitive to oxygen deprivation. And so, other parts of your body could go without oxygen for several minutes and not a huge issue. Your brain has about 3 minutes worth of glucose floating around it of sugar to use for energy. So if you deprive the brain of sugar or of oxygen for very long at all, it can be damaging. Less acutely than that, less intensely than that, if every night when you go to bed, you're dropping your oxygen level lower than it's supposed to be, you're starving your brain cells a little bit. So there have been some concerns about people that have chronic low blood oxygen levels, maybe at increased risk to have changes in their cognition. They may be at increased risk for different forms of dementia, things related to Alzheimer's. It doesn't cause Alzheimer's. It's not the same thing as Alzheimer's, but it can, in the end, give you the same result. And there's actually some evidence that it may increase your vulnerability to Alzheimer's. But the take-home message is chronic oxygen deprivation, even at a moderate level like that, is not good for our brains and can lead to worsening memory function, worsening concentration.
You do understand, what you guys understand what sleep apnea really is. We sort of alluded to the fact that it's the extra weight of the neck, but what's kind of interesting is if what you look for in a family member, for instance, it might be helpful for them to know. What you'd listen for is if you think about it, here's your airway, it's open like this, and when you're awake, everything's fine. As you start to go into deeper stages of sleep, that your muscles become paralyzed on purpose. That's so you don't act out your dreams. Most of us don't. There's a disorder where people do that, but most of us don't act out our dreams. But when we go into this deep stages of sleep, we relax all these muscles. Well, if you got a lot of weight pushing down on your airway, okay, what's going to happen? It's going to start to flatten out, right? And so as it starts to flatten out, what happens? The snoring starts. It gets a little louder. It gets louder. It gets louder. And then all of a sudden, boom, the person stops breathing. And you can, if it's a spouse or somebody that you're sleeping next to or in the same house with, you'll hear that snoring get really, really loud, and then all of a sudden...
It gets really quiet.
Wait, everything's really quiet, I don't hear anything. That's a little scary because they're not breathing at that point. And what happens, just for a few seconds, that happens. And what happens is the brain then says, whoa, hold on, put a stop to that deep stage of sleep. I can't go into deep sleep because I'm not breathing, I'm not getting oxygen. And I'm going to...
It's an emergency, you need to wake up.
It's an emergency, you've got to wake up. So what happens is the person then comes, instead of going into the deep stage of sleep, they go boom, right back into a lighter stage of sleep, and boom, that opens back up, and the whole process starts over again. So then as the brain says, okay, but I need my sleep, let me try again. So they start to go down and snore, boom, it shuts off. Same process again. So that happened to you 80 times in an hour.
Yeah.
That's not good, right? So that's what obstructive sleep apnea is, and the most common form of it is the weight on the neck that's causing it. So it gives you a little idea of what you're dealing with, and why they use. We didn't mention this much, but why they use the airway pressure. The way you treat it is you push pressure into the airway that pulls it open, so that even when your muscles get relaxed and that weight pushes down, it stays open enough that you can get air through there.
Right.
So, and they're uncomfortable things. You can describe a little bit about that.
This thing, how are you doing with your mask so far? Have you been able to use the machine?
Yes.
Okay.
And it's made a difference, but it takes getting used to.
It does, and some people really struggle with it, but I always encourage people, there are like a billion different masks out there. There's masks that cover just your nose, masks that covers a good chunk of your face, something called nasal pillows that just fit up against the nostrils. So I always encourage people, don't just stop using this, because this could be really life-saving for you. So try different masks and different straps and different headgear, because people usually are able to find something that they can live with. And at this point, well, I tell you what, I can't sleep. I don't know if it's just psychological at this point or what, but I can't sleep without mine now. If I go camping or if the airline loses my luggage, I'm sort of hosed. And I've got two. I've got one that stays at home in my nightstand, and I've got one that stays in my suitcase that travels with me. So I use it religiously.
Any other questions? Great questions, by the way. This audience always has great questions.
Good questions.
That's great.
I wish our dinner programs that we did just for all physicians had this questions.
That's right. Well, I wanted to thank Dr. Bojrab for coming. I very much appreciate it. This is an excellent talk.
Thank you.
And, thank you guys for all your questions. Next month I'm going to have a friend of mine and a colleague of yours, Dr. Vicki Dalton, is going to come and talk about eating disorders, so anorexia and bulimia and things like that. So, and then that should be the last one for the year, and maybe the last one, because we're running out of topics here. So thanks a lot for coming. I appreciate it.